Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Doctor, lately my sleep has been interrupted because I find myself needing to use the bathroom several times a night. It's getting quite disruptive. We had previously discussed adjusting the doxazocin I take for my prostate, but I haven't seen much improvement. I'm not sure if the medication needs more time to work or if we should try something else.
I understand that must be frustrating. Nocturia can really impact your quality of sleep and overall health. Let's consider increasing the medication dosage as a next step. However, it's also important to check if there's any other underlying issue contributing to this. How has your fluid intake been, especially before bedtime?
I've tried to reduce my fluid intake in the evenings, but it hasn't made much of a difference. On another note, I've been experiencing morning nausea most of the time. I've been taking ondansetron when it's particularly bad, which helps, but the nausea often returns.
Morning nausea can be quite unsettling. It's good that the ondansetron is helpful, but we should look into the root cause of this nausea. It might be related to your medications or another health issue. We'll need to monitor this closely. How about your reflux symptoms? You mentioned they've been worsening.
Yes, the reflux is another major concern. Despite taking lansoprazole and ranitidine, I often have discomfort at night. We had talked about the possibility of a hernia exacerbating these symptoms. I'm starting to worry it might need surgical intervention if we can't get it under control with medication.
It seems like the conservative measures for your reflux aren't as effective as we hoped. A surgical consultation could be the next step. It's important to manage this effectively to prevent any complications like esophageal damage. Switching topics slightly, how have you been managing your pain and other symptoms?
I occasionally use ibuprofen for back pain, which I suspect is from osteoarthritis. It helps, but I try not to take it too often because I worry about its impact on my stomach, especially with my current reflux issues.
That's a prudent approach, especially with your history of gastrointestinal issues. We might need to consider alternative pain management strategies that won't exacerbate your stomach problems. How have you been feeling overall with your heart valve condition and the medications related to it?
Managing the medications for my heart valve feels overwhelming at times, but I'm sticking with the regimen we discussed, including the baby aspirin. It's a lot, but I understand how important it is to keep everything balanced.
You're doing a great job managing a complex medication regimen. Let's review your recent lab results to ensure everything is on track. Your complete blood count and metabolic panel are stable, which is great. However, your glucose levels are slightly elevated. Have you been able to maintain the dietary changes we discussed, especially given your chronic kidney disease?
I have been trying to stick to the dietary recommendations, but it's challenging at times. I'm aware that my kidney function requires careful management, especially with my diet.
It's essential to continue those efforts. Your kidney function tests are stable for now, which is positive. We should also discuss your cholesterol levels. Your LDL is still higher than we'd like. We might need to consider adjusting your simvastatin dosage or making further dietary modifications.
I'll focus more on my diet and exercise. I know managing my cholesterol is crucial, especially with my heart condition.
Absolutely, and I'll help you with that. Given the issues you've raised today, your nocturia, reflux, and the ongoing nausea, I suggest the following plan. We'll schedule a consultation with a gastroenterologist about the possibility of surgery for the reflux. For the nausea, let's monitor it closely and consider potential dietary triggers or medication interactions as causes.
Thank you, Doctor. It's reassuring to have a clear plan moving forward. I appreciate your help in managing these multiple health issues.
Of course, it's my priority to ensure you feel supported and manage your conditions effectively. We'll schedule a follow-up after your gastroenterology appointment, and I'd like you to keep a symptom diary that we can review together next time. This will help us better understand the patterns and possibly adjust your treatment plan based on more detailed information.
Will do, Doctor. I'll start the symptom diary and look forward to our next appointment to discuss further steps.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Good morning. I understand there are several issues we need to address today, especially concerning your medications and overall health management. How have you been feeling recently with all these challenges?
Honestly, it's been overwhelming. All my medications ran out, and it's thrown everything off. I'm concerned about my heart without the warfarin, my energy levels are down without the thyroid medications, and my blood pressure isn't helping either.
I see. Running out of medication can indeed have significant effects, especially with your complex history. We'll make sure to address this immediately. You also mentioned some concerns about your voice since the surgery.
Yes, my voice has been hoarse since I had the valve replacement surgery. It's been quite frustrating as it affects my ability to communicate effectively, especially when I'm trying to resolve issues like these medication mix-ups over the phone.
Hoarseness can be concerning, particularly post-surgery. It's possible there could be an issue with your vocal cords, which we should investigate. Any other symptoms you've noticed?
My legs have been swelling up more again. I used to manage that with diuretics, but without them, it's been getting worse. And my weight's been fluctuating a lot too, likely from water retention.
Fluid retention and weight changes are significant, especially given your cardiac history. We'll look into that. How have you been managing with your daily responsibilities, especially with these health issues?
It's been tough balancing everything. I have my kids to look after, which means I can only do appointments in the morning. There have been several times I've had to reschedule because the clinic times didn't align with my availability.
We need to make sure your appointments fit your schedule to avoid any added stress. It's also essential for your treatment consistency. How has your experience been with managing your INR levels with the anticoagulation clinic?
It's been a bit of a roller coaster, honestly. Sometimes the levels are just right, other times they're not. It feels like we haven't found the right balance with the warfarin yet.
INR management can be tricky, but it's crucial for your safety, especially with your mechanical valve. We'll work on getting that more stable. Given all these factors, let's outline a comprehensive plan today.
I'd appreciate that. Just knowing there's a plan moving forward would help a lot.
Firstly, I will personally ensure all your medications are refilled today. You shouldn't have to worry about running out again. We'll also conduct lab tests to see where your INR is currently.
That's a relief, thank you.
Additionally, we'll arrange for you to have a regular schedule with the anticoagulation clinic. This should help stabilize your INR levels and reduce the risk of complications.
Regular monitoring sounds good. What about the swelling and these voice changes?
For the swelling, we'll restart the diuretics and monitor your response. As for the voice, I'm referring you to an ENT specialist to assess if there's any damage to your vocal cords or other issues that need to be addressed.
Will that be soon? The voice thing really bothers me.
I'll make it a priority. We'll try to get you an appointment within the next week. We also need to keep an eye on your thyroid levels and overall cardiac function, so let's plan a comprehensive review, including an echocardiogram in the next month.
That sounds thorough. How do we handle all these appointments with my schedule?
I'll work with our scheduling team to ensure all your appointments are in the morning. We'll also try to cluster your visits where possible so you're not making too many trips. Does that work for you?
That would be perfect. Managing the trips with everything else can be exhausting.
Understood. Finally, let's ensure you have support on all fronts. If there are any issues with medication, appointments, or just managing day-to-day, I want you to call our office immediately. We're here to make this manageable for you.
Thanks, Doctor. I really appreciate you taking the time to sort all this out. It's been stressful, but it feels good to know we have a plan now.
Of course, it's important that you feel supported and in control of your health. Let's start with the lab work today and get those medication refills processed. We'll review everything and adjust as needed on your next visit.
Sounds good. I'm ready to get started.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
It looks like your migraines have become quite frequent. We need to discuss preventive strategies beyond just medication. What steps have you tried before?
I've been using medication primarily, but I still suffer from migraines multiple times a month. Is there anything else that might help?
Yes, lifestyle adjustments can play a big role. It's crucial to identify your triggers, which can include certain foods, stress, or irregular sleep. Have you noticed any patterns?
Stress seems to be a big trigger, and my sleep isn't great either.
In that case, stress management techniques like meditation or yoga could be beneficial. Also, establishing a regular sleep schedule is important. We should also consider a preventive medication regimen if lifestyle adjustments aren't enough.
Could dietary changes help as well?
Absolutely. Avoiding foods that trigger migraines, which could include chocolate, cheese, or caffeine, is essential. Also, staying hydrated is key. Let's schedule a follow-up to monitor your progress and adjust the plan as needed.
Thank you, doctor. I appreciate the comprehensive plan.
Now look at question 26.
Thank you for joining today's session on our updated treatment guidelines. We have several key areas to cover, including changes to our protocols for managing chronic diseases and surgical care.
What specific changes are we looking at for chronic disease management?
We are shifting towards more integrated care models, emphasizing patient self-management and regular monitoring through our outpatient services. For diabetes management, for instance, we're incorporating newer, long-acting insulins and continuous glucose monitoring systems.
And what about the surgical care updates?
For surgical procedures, we're adopting enhanced recovery after surgery, ERAS protocols, which include preoperative nutrition, minimal invasive approaches, and early mobilization. This should significantly reduce recovery times and improve patient outcomes.
How will these updates be implemented across the hospital?
Training sessions are planned for all departments, and we'll be rolling out new digital tools to assist in protocol management. It's essential that everyone attends these training sessions to ensure smooth implementation and adherence to these updated guidelines.
Now look at question 27.
As we prepare for the transfer of the patient in bed 3 to the specialized care facility, it's important to go over her care plan in detail. She has been managing Parkinson's and requires specific attention.
I understand she has mobility issues. Are there specific instructions for her physical therapy?
Yes, she needs assistance with all movements and daily exercises to maintain muscle function. We've arranged for a physiotherapist at the new facility to continue her regimen.
And her medication and dietary needs?
All her medications are listed in her chart with specific timings and dosages noted. She's on a soft food diet due to her dysphagia, and this needs to be strictly adhered to avoid any complications.
I'll make sure to communicate all these details to the receiving facilities team during the transfer. Do we have a contact person there?
Yes, I've already coordinated with Nurse Thompson there. She will be overseeing the transfer. Let's also ensure that her family is updated about the timing and care arrangements.
Now look at question 28.
Today's training is crucial as we tackle the sensitive issue of medical malpractice and how to report it effectively within our institution. Understanding these protocols is essential for maintaining our standards of care and legal compliance.
What should our first steps be if we witness or suspect malpractice?
The initial step is always to ensure patient safety, then document every detail contemporaneously. Following this, use our internal reporting system to submit a report. This system is designed to protect your anonymity and ensure the issue is addressed.
What kind of follow-up should we expect after filing a report?
Our risk management team will review the report and initiate an investigation. Depending on the findings, actions may range from further training to disciplinary measures. It's vital that we all participate in creating a safe environment by not hesitating to report any concerns.
Now look at question 29.
I understand you're considering leaving the hospital against medical advice. It's important we discuss your concerns to ensure you're making an informed decision. What's prompting this decision?
I feel better and I'm worried about the cost of a longer stay. I think I'll manage fine at home.
While I'm glad you're feeling better, premature discharge could lead to complications that might require you to come back for more intensive treatment. This could end up being more costly in the long run.
That's concerning, but I still think the costs will be too high to stay longer.
Let's explore all possible options. We can consult with our financial counseling service to see if there are ways to reduce the burden. It's also possible we could arrange for some aspects of your care to be managed at home with regular follow-ups.
That sounds like a reasonable compromise. Can we discuss this with the financial counselor today?
Absolutely. I'll arrange a meeting for us right after this. It's important to me that we find a solution that maintains your health and also addresses your financial concerns.
Now look at question 30.
Good morning, everyone. Today, we are going to discuss how to effectively address patient complaints about care or hospital experiences. This is an essential part of improving patient satisfaction and our hospital's reputation.
What is the first step when a patient makes a complaint?
The first and most important step is to listen actively to the patient's concerns without interrupting. Then, we must thoroughly investigate the complaint by reviewing the patient's medical records, speaking with involved staff, and understanding the events that occurred.
How do we ensure the patient feels their complaint has been taken seriously?
We should communicate regularly with the patient throughout the investigation. Once a conclusion is reached, we meet with the patient to discuss the findings. We need to explain the steps taken to investigate the complaint and any changes that will be made to prevent similar issues in the future. Transparency and honesty are key to resolving complaints effectively.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.
Good afternoon, everyone, and welcome to today's detailed session on the progressive treatment strategies for rheumatoid arthritis, RA. I'm Dr. James Ellison, and I specialize in autoimmune diseases with a keen focus on rheumatology. Today we are going to dive deep into the intricacies of RA management through a comprehensive case study that exemplifies the evolution of treatment protocols and the remarkable impact of biologics in achieving remission. Our case today involves Mary, a 52-year-old schoolteacher who came to my clinic with persistent joint pain, swelling, and morning stiffness predominantly in her hands, wrists, and knees. These symptoms had been progressively worsening over the past 6 months. The characteristic nature of these symptoms, symmetric polyarthritis, along with significant stiffness in the morning, raised an immediate concern for rheumatoid arthritis. Upon her first visit, we conducted a thorough physical examination and ordered a series of blood tests. The results showed elevated levels of CRP and ESR, markers commonly associated with inflammation. Additionally, Mary tested positive for rheumatoid factor RF and anti-citrullonated protein antibodies, ACPA, both of which are highly indicative of RA. With the diagnosis confirmed, our initial treatment strategy for Mary involved methotrexate, a standard first-line DMARD. Methotrexate is known for its effectiveness in reducing the progression of joint damage and preserving joint function. However, Mary's response was suboptimal, and her quality of life remained compromised, which is often a challenge we face in rheumatology. Given the inadequate response to methotrexate and the ongoing active disease state, evidenced by her persistent symptoms and elevated inflammatory markers, we decided to escalate her treatment. This included the introduction of low-dose corticosteroids aimed at providing a more immediate control of the inflammation. Corticosteroids were chosen for their potent anti-inflammatory effects, providing relief from acute symptoms. However, the use of steroids is generally limited due to potential side effects over long-term use, such as osteoporosis, hypertension, and diabetes, among others. Therefore, their use in Mary's case was carefully monitored and intended as a short-term strategy while considering further therapeutic options. After several weeks, despite some initial improvement, Mary's condition plateaued. This led us to the next pivotal decision in her treatment plan, the use of biologic DMARDs. Biologics represent a revolutionary class of drugs that target specific components of the immune system that drive inflammation in RA. We started Mary on a TNF inhibitor, one of the most effective classes of biologic therapies for RA. TNF inhibitors specifically block the tumor necrosis factor, a key cytokine involved in the inflammatory process of RA. The impact on Mary was significant. Her symptoms improved remarkably, and her functional ability was restored, allowing her to resume her full-time teaching duties. Her follow-up assessments showed a substantial reduction in CRP and ESR levels, and imaging studies indicated no further progression of joint damage. This outcome highlights the crucial role of biologics not only in managing symptoms, but also in altering the course of the disease. Mary's case is a prime example of the treat-to-target strategy recommended in RA management. This approach emphasizes the importance of setting remission or low disease activity as a clear goal. Treatment should be adjusted dynamically until these targets are achieved, ensuring the best possible outcome for patients. This strategy, combined with the advent of biologic therapies, has transformed the landscape of RA treatment. The goal is no longer just to alleviate symptoms, but to achieve sustained remission, thereby preventing joint damage and maintaining function. Mary's journey from diagnosis to successful disease management underscores the importance of timely intervention, the effectiveness of modern therapies, and the necessity of personalized treatment plans in managing rheumatoid arthritis. Her case is a testament to the advancements in medical science and the real-world impact these have on our patients' lives. Thank you all for your attention today. I hope this discussion provides deeper insight into the modern management of RA and inspires continued excellence in patient care.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Today, we delve into the complex and challenging topic of pyrexia of unknown origin, PUO, a condition that remains a puzzle in clinical medicine despite advances in diagnostic technologies. The term PUO was initially coined in 1961, defining it as a fever of 38.3 degrees or higher, lasting for more than 3 weeks, with no obvious cause after 1 week of inpatient investigation. However, this definition has evolved with medical advances, emphasizing the importance of an extensive and intelligent diagnostic workup, irrespective of hospital stay duration. Let's discuss a case study that highlights the intricate nature of diagnosing and managing PUO. Mr. Smith, a 45-year-old male with no significant medical history, presented with persistent fever of 38.5s for 4 weeks. He reported associated symptoms like night sweats and significant unexplained weight loss. His extensive medical evaluations, including full blood count, liver and renal function tests, and inflammatory markers such as CRP and ESR, initially returned within normal limits. Despite comprehensive imaging, including chest X-ray and abdominal ultrasound, and multiple sterile blood cultures, the cause of his fever remained elusive. The next phase of our investigation considered more specialized tests given the non-revealing initial workup. We included tests for HIV and other infectious agents, such as Epstein-Barr virus and cytomegalovirus, which all returned negative. This broadened the differential diagnosis to include infectious, neoplastic, and autoimmune diseases as potential culprits. Considering the possibility of an occult neoplasm or a granulomatous disease, we progressed to advanced imaging techniques. A CT scan of the chest, abdomen, and pelvis was performed, revealing a small, indeterminate lung nodule. This finding prompted a deeper dive into Mr. Smith's exposure history, which revealed recent activities involving extensive renovations of an old house. This was a critical piece of history that brought to light potential exposures to various antigens, including molds and fungi. The diagnostic journey continued with a bronchoscopy and bronchoalveolar lavage, which yielded a culture positive for Aspergillus fumigatus. This mold is commonly found in soil and decaying organic matter, fitting with Mr. Smith's exposure during house renovations. The diagnosis of a fungal infection led to the initiation of targeted antifungal therapy with voriconazole, which resulted in a gradual resolution of his symptoms over several weeks. This case underscores several key aspects in the management of PUO. First, the importance of a thorough and repeated collection of the patient's history cannot be overstated. It is often the detailed, sometimes seemingly inconsequential patient histories that guide diagnostic pathways. Secondly, PUO demands a flexible, stepwise approach to diagnostics, starting from basic tests and advancing to more specialized investigations as needed. Moreover, this case highlights the need for a multidisciplinary approach in managing PUO. Infectious disease specialists, radiologists, and pulmonologists played pivotal roles in unraveling Mr. Smith's diagnosis. Such collaboration is essential in managing complex cases where multiple systems may be involved. In clinical practice, it is crucial not to rush to label a fever as PUO without exhaustive and methodical evaluation. The initial workup should be comprehensive, including a detailed physical examination and a broad range of laboratory tests. Early imaging should not be overlooked, and depending on the clinical suspicion, more targeted scans may be warranted. Another important aspect of managing PUO is patient communication. It is vital to keep patients informed about the nature of their condition, the potential for a prolonged diagnostic process, and the possibility that, despite extensive investigations, a definitive cause may not always be found. In cases where the etiology of the fever remains unknown, it is essential to reassure patients about the generally favorable prognosis while maintaining vigilance for new symptoms or changes in their condition. PUO remains one of the most challenging puzzles in clinical medicine. Each case should be approached with a comprehensive, methodical strategy, leveraging both traditional and advanced diagnostic tools. Continuous updates in medical knowledge and technologies, alongside a multidisciplinary approach, are crucial in improving the diagnosis and management of this perplexing condition. Clinicians must act as medical detectives, using every piece of available evidence to solve these challenging cases, ensuring the best possible outcomes for their patients.